Absolutely, thank you. I'm super excited to be here. I love social work. You know, I have my BSW and my MSW, so I'm all social work all the time, and I love community mental health. So even if it's not your dream job right now, maybe today after my presentation, you'll think a little bit more about wanting to work in a clinical practice in community mental health. So a little bit about us. I was the interim director when I sent you that. I'm currently the director, so my position is permanent now. I'm very happy about that. I'm a licensed clinical social worker and a clinical substance abuse counselor. My background, like Nick said, is working with people who have co-occurring serious mental illness and substance use disorders.
All right, good afternoon or good morning, afternoon everyone. So I'm Shellee, I'm the HR specialist for Bell Therapy. I specifically support Rebecca in all recruitment efforts as far as hiring case managers, clinical coordinators, program managers, and so we work very closely, and happy to be here today with Rebecca and then also with you guys to share a little bit about our organization and some of the openings we have, and then also about community mental health.
Okay, so Shellee's going to share a little bit about Bell.
Yeah, so how many of you guys have heard of Bell Therapy or Phoenix Care Systems? No one, right? So we currently reside in Milwaukee, and Phoenix Care Systems provide mental health services for our clients and consumers. Under Phoenix Care Systems is Bell Therapy and WILLOWGLEN. So Bell Therapy is geared towards our adults population, and WILLOWGLEN is geared towards our kids population. Under Bell Therapy, we offer a variety of services, and so as you can see from our presentation, we have residential. Specifically in Milwaukee, we have over 25 group homes within the Milwaukee area. In addition to residential, we have our community services, which includes our community support program, our comprehensive community services, our day program, and then our outpatient clinic. On the flip side, WILLOWGLEN, as I mentioned, is really geared towards our kids program. So our care coordinators work closely with the kids and their families to provide structure and support. We do currently operate in 5 different states, so Wisconsin being where our headquarters or corporate location is. So that's Milwaukee, and then Illinois, Indiana, New Jersey, and South Carolina. A lot of people ask us, what is the culture of Bell Therapy? I like to say it's a culture of quality. So we want to provide the best quality care to our clients and consumers. Not only that, but it is a very respectful, friendly, kind of family-oriented organization. And so to be a part of Bell Therapy is really rewarding, and that's why we're here today to kind of talk about Bell Therapy and some of the opportunities that we have.
Okay, so what is community mental health? This is not a formal definition by any means, but it's really my view on what community mental health is, because that term is thrown around pretty loosely, and I think sometimes we don't really know what it means or what people are trying to convey when they say community mental health. So for me, it's a loose term to describe, work that's either done in the community or done in an office with a specific community, typically really high needs. These are going to be people who are impoverished, low income, maybe a serious mental illness, something that would make them different than the sort of quasi normal society that we would think of. It's often a highly clinical role. Your title may not always be therapist or clinician, but what you're doing is really a micro practice, and it is very clinical, even though you're in a community type setting. So when we think community, we often think macro. So we're working in a macro setting, but very much on a micro level. So it really utilizes the tools and the skills of what I think have to be well-trained social workers, because it is a complex position. You're working with people who have very complex needs. You're doing things to coordinate, case manage, and provide psychosocial rehabilitative services, meaning everything you do is clinical. Taking somebody to the store is clinical because you're teaching them how to go to the store. You're teaching them how to read a label. You're all working together, as a team of providers to help people on a recovery journey. So even when we think of people who are living with schizophrenia or maybe a bipolar disorder, something that would be considered severe, we always think of recovery as being an option, and people working along a path of recovery. So it includes components of therapeutic interventions. You learn about therapeutic interventions in school. Does anyone have any that they're really hot on right now? Do you guys talk about any of that? Anyone taking any clinical classes? Anyone? Are these not normally interactive? I'm sorry, I'm a chatterer, so it's going to be interactive. So we're thinking about things like maybe certain models or maybe just theories or modalities, things like motivational interviewing, cognitive behavioral therapy. Those are some of the big hot ones right now. DBT therapy is also a really popular one right now. So you may be taking elements of that out into the community and working with people and engaging them outside of a traditional office setting. So you're often adapting to meet complex needs. I often think, of clients sometimes being dually diagnosed, and a lot of times that would be, a substance use and a mental health disorder. But we also have people who are dually diagnosed with an intellectual developmental disability. We have very complex physical health needs, things like hepatitis, HIV/AIDS. We have complex needs when it comes to housing and homelessness. So a variety of different things that all are sort of comorbid together. And it's your job to figure it all out. No pressure. So what type of work are you interested in? I'm kind of curious if there's anyone who has heard of community mental health, or maybe you're interested in working in the community. One? All right. I'm going to convince you, all of you.
I am a community social worker.
Perfect. I love that. Okay, so maybe you can, I'm going to be looking to you to chip in on some of this stuff here. Okay, good to know. So I think as a social worker, it's something that all of you should consider. Even if you know you want to work in a hospital, understanding the elements of community mental health are important, because you could be doing that in a hospital setting. Even if you're confined to your office, you're going to have people coming to you that have these types of needs. Being able to navigate the systems will be really essential. So some typical centers or places where you would see people is like a federally qualified health center or an FQHC. These are people who are coming to a clinic in a designated area that is, it's impoverished. So the federal government has poverty guidelines, and there are certain clinics set up in areas to meet the needs of people in those areas, and an FQHC would be one of them. You also have things like community mental health centers, which are kind of similar, usually in certain areas designated to help people with specific needs. You could be doing sort of homeless outreach work, alternative therapy settings. There are some providers who are full-time psychotherapists, but they don't meet in an office. They go out into a community, they meet with people, under a bridge, or they meet with people in a McDonald's parking lot or something like that, which I really think would be very, very cool. You could be in a jail, and when we think about community, you're certainly not in the community. People are incarcerated, but they're there for a short period of time, and what we know about the correctional system is we have lots of people coming in with untreated mental health issues or concerns and very complex needs. You could be working in an office. You could be, do you have a question?
Actually, I was going to say, I got my MSW here, but I got diagnosed about 30 years ago, and I came very close to being put in jail myself.
I believe that.
Pardon?
I believe that, yeah.
Yeah, so that's something, I think people need to keep in mind.
Mm-hmm.
My destiny is, not just there.
Mm-hmm.
It's anybody can end up there.
Yeah, absolutely. There's a lot of criminalization of mental health issues. We see a lot of people engaging in behaviors that are directly correlated to their symptomology spiking. And so people may have sort of an outburst of symptoms. And we know that symptoms ebb and flow, and sometimes people do really well and they're in a recovery place, and other times they're struggling, just like anybody that would have a chronic health condition. And so when people are really at the peak of what's going on symptom-wise, they can participate in behaviors that lead to criminalization. And that's why they need advocates like you all to be present, to be able to say, let's back up and see what we can do. How can we make sure that this person has all of their needs met so that they can go back and participate in society? A lot of the individuals that I personally work with are on some sort of community commitment or stipulation. So these are folks who are court-ordered to treatment due to participating in a variety of behaviors or just having a extended pattern of instability. And we're going to talk a lot about clinical case management today. That's really the meat and potatoes of what I want to get into. So these are some of the roles you may find in community mental health. Clinical supervisor, intake specialist. You could be an outpatient therapist working with a special group of people who are coming to you but who have very complex needs. crisis worker, or an outreach worker. So like I said, I'm going to focus on case management. I've been a case manager. I now currently supervise a plethora of case managers. So it's very much ingrained in what I do on a daily basis. So what is clinical case management? You're really meeting basic needs through highly clinical interventions, and that's not always what we think of when we think of case management. We sort of think of pushing papers and making referrals, but in this type of setting, adding that clinical in front of case management means that you have to have some skills. You have to have some training and education in a clinical setting to be able to meet the needs of the people that you're working with. So everything is psychosocial rehabilitative. You're not just doing things for people, you're teaching people how to do things for themselves. This could take years. You could spend 5 years going grocery shopping with somebody, but the ultimate goal is that one day they're going to be grocery shopping on their own. And we do. We have people who we grocery shop for years. You know, there are some people in our program that have been in our program for 20 or 30 years, but the goal is always still recovery and moving them closer to independence. So daily therapeutic communication is an orientation. It's something that you have to get comfortable with, and you have to recognize that everything is clinical. That every conversation that you have with someone, regardless of it's about their payeeship or it's about vacuuming their apartment, all of that can be done in a therapeutic way to get a sense of what's going on with the person and how you can help them. This is a tough concept for people, actually, believe it or not. You know, we hire lots of case managers who don't understand that anything can be clinical. And I hear, well, I'm not a babysitter, or, you know, I'm not going to do everything, I'm not a maid. But the reality is, cleaning an apartment with a client alongside you could actually be a very therapeutic intervention. If you're teaching the client, you know, what types of items are trash and what types of items should be saved, or how to organize your papers, all of that could be very clinical. Okay, so I'm really going to focus on CSPs as my example because I think this is like the gold standard in clinical case management. It has tons of different areas that I'm going to dive into today. And historically, it's just a really, really great example of where clinical case management came from. So does anybody know what a CSP is? Do you work in a CSP? This is going to be so boring for you. No, I'm just kidding. Which CSP do you work in?
Forward Solutions, it's part of Journey Mental Health.
Okay, and here in Madison then. Mm-hmm. Okay, interesting. Well, I'm sure you guys probably do things very differently than we do things in Milwaukee, so I'd be interested to have you pipe in and talk about anything. Okay, so what is your role in a CSP?
I'm a case manager.
You are a case manager?
Clinical case manager.
Clinical case manager?
Can you state one more time what's CSP?
Yep, I'm going to ask her to tell you what it is.
Community Support Program.
Yep, so a CSP is a community support program. It is the ultimate textbook example of you know, taking something from your book that you learn in school into the actual real world. CSPs started when deinstitutionalization happened. You all learned about deinstitutionalization. You know, we decided that people needed to be in the least restrictive environment, and so we took everybody out of institutions and put them into the community, and we said they're not going to become locked up unless they're a danger to themselves or others. So what that means is that we needed to create a variety of programs in the community to support individuals so that they weren't a danger to themselves or others. Thus, CSPs were created. And the regulations that govern CSPs are about as old as deinstitutionalization. They haven't quite caught up yet, but they really tell us all of the things that we need to do to keep people safe in the community. So in Milwaukee, and I don't know about Madison, but you can comment on it, we use ACT and IDDT, which is Integrated Dual Disorder Treatment and Assertive Community Treatment. As a community, we decided 3 years ago that we were going to transition all of our CSPs into using this model of care, even though it was originated here in Dane County in like the 70s. Milwaukee's just catching up. So at our agency, we started our implementation about a year ago, and it is like a 3 to 5 year process to really fully integrate this into the services that we provide. It's a team-based model, so everybody on a team of interdisciplinary professionals, including clinical case managers, nurses, psychiatrists, mental health technicians or aides, they all work with a shared caseload of individuals, and everybody helps everybody instead of just having, you know, your little set group of clients that you work with. Do you guys use ACT or IDDT?
Yes, we use the ACT model.
Okay, interesting. How long have you been using it? Since the 70s?
Or probably, yeah, I'm pretty sure.
Yeah, so it did start here, and this is an evidence-based practice, and it's used all over the country. And of course, Madison is really like the flagship for that. It was started here, so I don't know why it's taken Milwaukee so long to catch up, but I think that's with a lot of things. So.
Would you repeat what IDDT means?
Yeah, it's integrated dual disorder treatment. So it's a special training and a type of practice that really looks at people who have both substance use and mental health issues. So when you put people into 4 different quadrants, we're really looking at quadrant 4 people, which is people that have severe substance use and severe mental health issues together. So this is really the toughest of the tough population. So for staff classifications, I already kind of mentioned some of them. Case manager, clinical case manager, oftentimes they're called a clinician. At our clinic, we do call everyone a clinician. We do have mental health technicians who support the case managers, and we also have clinical coordinators who provide daily clinical supervision. For our clinical case managers, we typically always hire somebody with a master's degree. We occasionally make an exception and hire somebody with a bachelor's degree, but it is more of a rarity. We really like clinicians to be seasoned whenever possible because this is a very tough population, and so we want people who can meet the needs of our clients. Yes?
Do you guys require SACs typically too?
No, we don't require SACs. As a company, we're looking at getting everybody substance abuse certified, so we are working with the state to create a special training program just for our staff to meet the 360-hour requirement that the state has, but we do have some who have a SAC and some who don't.
Master's degrees in what?
So it has to be in some type of behavioral health field to meet the qualifications of the chapter that governs this program. I'm partial to hiring social workers because I'm a social worker. I think that there is a difference between getting an MSW and getting a degree in human services or counseling. And I've noticed that hiring social workers is a different experience because they're more prepared to deal with the complex needs and the variety of challenges that transpire. So, are you all social workers? Good. I would say it's a group of therapists or a group of LPCs too. It's just a different perspective. Okay, so these are some of the services that are done by our clinical case managers. They provide treatment, rehabilitation, support, case management, and that's it. However, each of these has a variety of different elements underneath them, and I'm just going to go through them. I would love for this to be interactive. Even though I have a PowerPoint, it's really just to keep me on track, to make sure I don't forget to say anything. But you can ask questions and throw your comments out, and I'm very comfortable with that. So when we're looking at treatment, we have things like outreach and screening. It's expected that we have practices to go out into the community and find people for this program. If our client is not interested in coming to the office and lives under a bridge, guess what? We're going under that bridge, and that's where we're serving the client. 75 to 80% of our day is spent in the community with the people that we serve. It's an exception more than anything else that they're coming to the office or expected to come to the office. We do assessments, so we do an initial assessment to gather basic information, and then we do an in-depth assessment, which is kind of like a biopsychosocial, where we're really gathering all of the history on the person to build a treatment plan. We're constantly doing treatment planning and reviewing. We have to have a new treatment plan at least once every 6 months, and it has to be reviewed at least once every 6 months. The clients are very involved in that process. We currently use what's called individualized recovery plans that utilizes the client's words, their own goals, their hopes, their natural and professional supports. We bring all of those people together to try to support the individual. We do provide crisis intervention services, which means 8 to 4. We're jumping in the middle of a crisis. We're assessing what's going on. We're helping solve that situation. It also means that we're available 24 hours a day, 7 days a week. So we do have a crisis phone number. It's more rare than anything that we'd actually be going out into the community at 2 o'clock in the morning, but we're doing a lot of supportive psychotherapy and therapeutic listening and things like that over the phone. So people have access to us 24 hours a day, 7 days a week. That's on a rotation. We do symptom management and supportive psychotherapy. Symptom management means that we are aware of the symptoms that our clients have at any given period of time, and we see our clients frequently enough to know when a symptom has changed, either escalated or gotten better. So there's a lot of communication that takes place between the clinical case manager and the clinical coordinator who supervises their work. It's expected that the case manager be in regular contact with the supervisor to talk about symptoms, what they're noticing, what they're observing. We have some clients that we see 7 days a week. In those 7 days, maybe the visits are 15 minutes a day, but we're certainly meeting with them to see, maybe doing a mini mental status exam, checking on their cognitive functioning, looking at their environment to see if it's deteriorating. We're checking to see how alert they are, if they're internally preoccupied in any way. What symptom management doesn't mean is that I have new clinicians sometimes that are like, I'm gonna do symptom monitoring, and that's, hello Nick, are you experiencing any symptoms today? And Nick's like, no, I'm not experiencing any symptoms. That really is not an effective way to manage symptoms. What we expect our staff to do is actually go in and be really observant, to have a conversation. And even if you ask them, what did you do today? And the client gives a response, it could be nothing about the symptoms, but you could learn so much about what's going on by their pace, how loudly they're speaking, if they're speaking to anybody else in the room, if they're mumbling, if they're completely mute. And those would all be things that you would document and talk to your supervisor about. Supportive psychotherapy is happening on a daily basis. Our people are going through so much stuff. They're stigmatized, they're traumatized, they're dealing with the fact that they have this serious mental illness. Many of them have family members who also have serious mental illness. There's a lot of housing instability. Many of our clients are on Social Security or supplemental security income, so there's a lot of poverty. So we're constantly doing supportive psychotherapy to make sure that everybody is staying safe. We're doing ongoing assessments, providing education. This is often psychoeducation about either their symptoms or how to manage their symptoms. Teaching behavioral symptom management techniques. So with our group of folks, because it is a serious and persistent mental illness, they are expected to have this forever. It is going to be of a long duration. We're not doing in-depth psychoanalytic work. We're not doing Freudian work. We're not sitting in an office and going in-depth about their childhood. We may be talking a little bit about trauma that they experience, but it's usually in the realm of what's currently happening with them, what symptoms are being perpetuated by this trauma, and then how do we employ some behavior management techniques to address that. And we're always promoting personal growth and development. We're a very strengths-based program. I personally believe that recovery is possible for anybody, even the person with the most serious mental illness. And so we're always working towards what recovery means for them and how to get people there. My personal goal for every client in our program is to figure out, what do you want out of your life, and then how do I help you get there? I think Nick mentioned that I've worked as a psychotherapist. I've done office-based psychotherapy. That's always been my goal, even just in doing therapy with people, is what do you want out of your life, and then how do I help you do that? And then that's the course of the therapy, is figuring it out and supporting them along the way. Okay, rehabilitation. This is super, super cool. So we currently have a job program for some of our clients at our agency. So we have a small cohort of folks who do custodial work, and they are employees for us, and they do get paid. And we also have what's called a snack shop, which is a client-employed snack bar, I guess you could say, where we have a variety of snacks and things that other clients can come in and purchase. So this really falls under the rehabilitative services because it's all employment related. The expectation is that if people want to work, they can work. There was a survey done, and I'm not gonna be able to quote my research, but I remember the statistic, I'm not just making this up. It was an empirical journal, and they went out and they did some qualitative interviews, and they interviewed people on SSI, and they found, I think it was roughly 80% of the people on SSI wanted to work. The trouble is that our community does not want people on SSI to work. People don't want to work with individuals who have a serious and persistent mental illness, for the most part. That's not my issue. I don't believe that personally. I think that work is for everybody. Civic participation increases self-esteem, it increases people's social skills. There's so many benefits from working even a part-time job of 10 hours a week. So we always encourage work whenever it's clinically appropriate. We can help them with things like On the job performance evaluations, we can actually go to their job if they're working outside of our clinic and work with them on the skills that they need to get to do their job. We can provide individual vocational counseling, help with things like resumes or soft skills training, stuff like that. Any really work-supported services. Maybe somebody wants to go into construction, but they need construction boots or a special hat. We would really be sitting down and figuring out how can we make that happen for this person so that they can get involved in the community. And we definitely work a lot on identifying behaviors that interfere with work performance, because the goal is not to just get somebody a job, but it's certainly to maintain the longevity of the employment. So we can help people with that. So I think that's not something we necessarily think of when we talk about case management. This is like one of my favorite things, social and recreational skills training, because this means you can do anything. We take clients to Brewers games, and it's billable. It's a clinical experience, because we're not just going there to watch the Brewers, we're going there to have conversations about people's anxiety being around other individuals. We're going there to talk about what it's like to sit for 2 hours or 3 hours in one seat and not be moving around. We're even talking about what it's like to go somewhere and not smoke a cigarette every 15 minutes. So there's all sorts of different things that we're teaching people, and we're learning, and we're doing behavior management techniques with, even at a Brewers game. Who doesn't want to get paid to take their clients to a Brewers game? You know, you could really do anything. Anything could be psychosocial rehabilitative. We're thinking about taking our clients to the zoo. Like, that's a fabulous idea. So support, this is a very general term, but it means pretty much what it says. We're supporting people to meet their physical and their mental health needs. So we're setting up doctor's appointments. We're making sure that everybody sees a dentist and a doctor at least once a year to make sure that they're staying healthy. Legal services is really important. We already talked a little bit about the criminalization of mental illness. So we're helping people with any issues that may come up pertaining to the law. That might mean coordinating some pretrial services to avoid sentencing. It may mean our clients are incarcerated and we're going to go visit them in jail. There is a tendency in some CSP programs to neglect the individuals who are either in the hospital or in jail because everyone is really, really busy, and it's sort of like, okay, the jail is taking care of them. My perspective as the director is that when somebody is institutionalized, that person is so isolated that they need us way more than ever. And we need to make every effort to actually physically get to the jail, get to the hospital, and make sure that we're seeing them and planning for the discharge. You guys go to jail? None of your clients go to jail, right? No, I'm just kidding.
No, we do. The only problem I was thinking about with that is that it's not billable when you go to jail or you go to other institutions. So that's also somewhat could be a reason why people are like, well, I won't go see them 1 hour a week like I normally would at their home because...
So the toughest thing is that's not billable unless you're talking about discharge planning. And if you're talking about discharge planning, it is billable, in which case we're always talking about discharge planning. We're planning somebody's discharge for the moment they're incarcerated or the moment that they're brought into a hospital, because there are a lot of things that need to go into planning a discharge. There's a lot to consider. Where is this person going to live? Are they on any sort of registry? Are their benefits going to be cut off while they're incarcerated because they've been there too long? So lots of stuff to consider, and all things that take great amounts of time. So we're discharge planning from the beginning. A little work around there. Every note. Went there to discuss discharge planning and other things.
Can I just ask a quick question about that, since we're talking about the legal end of things? I noticed that, I mean, other than Eau Claire right now, there's no mental health courts. And the VA has a mental health court that they've started here in Madison. And it just seems to be, with the success that drug court has had, that there would be at least more of an effort towards diversion away from the criminal justice system. And with agencies like yours that addresses some of that, I wonder if there is a part of what you do that advocates with the criminal justice system about trying to get something initiated. And I know they've talked about it here in Dane, but I don't see that happening yet.
Yeah, I would say that our biggest challenge in Milwaukee is that our systems are not very well coordinated right now. The best thing we have going for us is the mental health redesign, which is a very coordinated effort on the part of the entire county of Milwaukee, and that mental health redesign actually has a board of people overseeing the process. I'm on the steering committee for a group called the Milwaukee Co-occurring Competency Cadre, which is a very silly name. We just call it MC3. We have roughly 1,200 people who participate on a monthly basis regarding co-occurring issues, and we just appointed or recommended to the state 2 people from the Milwaukee area to be on that mental health board. Some of the individuals on the mental health board are from the criminal justice system, but it's a loosely coordinated system at best right now, and so I think our best strategy is to really rally those people together, and it certainly is the part of the social worker to get on committees and to advocate and to push for more coordinated care. We have a pretty big continuum of care in Milwaukee that addresses issues of homelessness, where there's also a lot of co-occurring mental health and criminal activity. And so we're working on engaging that group as well. That group has had pretty good luck with engaging the criminal justice system. We've had a lot of unique things happening in Milwaukee. We also, our criminal justice system was just privatized about 2 years ago. So a company from Florida came in and took it over. Those positions used to be county positions, and now it's Armored Correctional Services. And so, you know, they've been a little difficult to engage with. This is on tape, but you know, they're from Florida, and so you know, figuring out how to navigate that private sector has been a challenge. So to get back to your question, I would say that advocacy is a huge role, and I think I actually have a slide on it in my PowerPoint. So taking the opportunity as a clinical social worker or a case manager to participate in external committees is really important, not just for your own personal growth and networking, but to be able to make a difference, big picture, in the day-to-day lives of your clients. So I completely agree. There is an element of that macro practice and everything too, participating in those groups and trying to coordinate the efforts. So financial support. This would be anything that your client needs: budgeting, help with banking. We're the representative payee for an overwhelming majority of our clients, meaning that the legal system and Social Security has found them legally competent to sort of manage their funds, and we do that on their behalf. Are you at like 1 million people's representative payee?
Approximately 13.
Yeah.
I mean, me personally.
Yes.
Do you provide any direct financial support when people need?
Not typically. It's rare that we do that. I mean, everything that we do is funded through Medicaid. So the Medicaid reimbursement rate is pretty poor, and we're billing straight Title 19. So there's not a surplus of funds to really support people with their financial needs, but we're really honing in on more of the helping them to budget and bank and find resources to supplement their needs.
And is that enough for what their needs are?
You know, it's hard to say. We do have a lot of people who are living in poverty, and it is quite unfortunate, and I think that's, again, where the advocacy comes into play and trying to assist people. If you're going to be a case manager in the community and you're going to work in this type of clinical setting, you have to be very, very crafty. You have to be a really excellent networker and be able to find all of the resources that exist in your community, because your clients are going to need that because they don't have all of their needs met. One thing that we do is try to get everyone into subsidized housing. We do have a pretty small housing stock in Milwaukee of affordable places to live, but we work pretty hard to get people into units where they're paying only 30% of their income, which shows that there's a greater chance that they'll be able to maintain that unit. Okay, so these are all things, everything I've talked about so far is something that a case manager would actually do. A case manager, a clinical case manager, clinician, whatever term you want to use. And then we haven't even gotten to the actual case management yet. The case management, it's an organized process for providing a full range of appropriate treatment, rehabilitation, and supportive services to a client in a planned, coordinated, efficient, and effective manner. This comes straight from the state statutes that really dictate how we provide care to people. So that's taking everything I already talked about and making sure you stay on top of all of your work. Making sure things are done in a timely fashion, that your notes are done, that there's appropriate billing to back up the services that you've provided. And it means being there to help your client with just about anything they need. So there are some specific services that we look at under case management. There is some crossover in the other things that I've already talked about. But you're doing things like coordinating referrals. This could be housing referrals, food referrals, dentistry referrals, childcare referrals. Many of our clients have children. Monitoring their symptom status. Again, not just saying, do you have any symptoms today, sir? Or ma'am, are you experiencing any symptoms? But really being present in the moment, making sure that you have time to dedicate to that professional, to be aware of the surroundings, and to really be cognizant of what's going on when you're engaging with the person. Supportive psychotherapy and education. Again, we're doing this all the time. We at my clinic have a small, very small individual psychotherapy program, and it's really an oxymoron. It doesn't make any sense because everything we do is psychotherapy, and our clients clinically just do much better in a group setting because of the symptoms that they have. But we do have a couple people who benefit from this individual therapy. It is very much office-based. They come to us, they sit down, we engage with them therapeutically. But it's kind of silly to say that we have this specialized program because it's not really anything separate from everything else we do. Taking somebody to the grocery store, you could have the same therapeutic interaction that you would have in that office. Advocacy, I knew it was in here somewhere. So that means advocating for your client, but also advocating for systems changes as well. I think that's a really good point, actually. I'm glad that you brought that up. Your clients need some advocacy too, though. Housing advocacy is a big one. I know you guys probably don't have this issue in Madison, but we've got a lot of housing discrimination that happens in Milwaukee. You know, when I call on behalf of my client, I get a very different response than when my client tries to call on their own. So a lot of times we'll sit side by side. I'll do a call, they'll do a call. They'll kind of watch how I do it, pick up on the lingo. Again, trying to be rehabilitative and teaching them how to do that. Education, support, and consultation with the family. So there's this idea that so many of our clients have burned bridges with their family members, and I don't like to think of bridges as being burned as much as they are a bit broken. I think no family ever really wants to fully cut off a member, but it may mean that they're not interested or willing to engage with them at the level that they did in the past. So maybe they're not willing to let Johnny come stay with them anymore, but they're willing to meet up at a park 1 hour a week or once a month. So trying to connect the person to their family is important, providing education to the family about symptoms, about what they're seeing, or maybe why their family member is doing the things that they're doing. That's really important. And we do provide consultation with family because, families, they get worried. They care, and they need somebody to talk to. We get a lot of calls from parents and things like that. Of course, we have a release of information. Usually they're on the treatment plan. The client's very comfortable with it, and if not, puts us in a little tricky situation, but at that point we're usually circumventing the family and not really engaging with them. I already mentioned this, but I'll mention it again, is that because some things can be familial, we do have clients who have parents or siblings who also have serious mental illness, and that can be sort of a challenge to kind of navigate those relationships. And so sometimes we find ourselves providing support or psychoeducation about illnesses to the family members that have those illnesses, in addition to the clients we're directly serving. And we're coordinating their treatment. So all of our clients see a psychiatrist in our clinic. He or she, they're big players in what's going on. They see our clients, at least once every couple months at the minimum. Every time they leave a hospital, or if they spike in a crisis or there's an acute issue, they're coming in, they're seeing the doc, so we're coordinating all of that. We have things in here that I already talked about: assessments, developing and implementing the treatment plan, working with the other staff, and organizing specific staffings and things. Okay, perspective shift. I threw the slide in there. It's literally one line, I believe. Nope, it's a couple lines. It's a couple lines, but the main line is at the bottom. And that the main line is really that anything can be done in a therapeutic way. All of these things, conversations about payee ships, handing somebody their medication, taking somebody to the bank, driving somebody in your car, taking somebody for a walk. All of that could be psychotherapy. So I just really, if you take away anything from today, want people to recognize that psychotherapy can be done outside of an office setting, and that it can look very different and still be really highly impactful and meaningful for the client. Okay, typical qualifications, I already talked about this. Usually our case managers or clinicians have a master's degree. Our mental health technicians typically have a bachelor's degree. Sometimes they don't have any degree. We do have one person who's a CNA. She's worked with us for 20 years. We can hire those folks based on their aptitude. Our clinical coordinators always have a master's degree. We do like people to be licensed. Sometimes they have a training license. They need at least 1,500 hours working in a CSP because, again, those are really the people providing the day-to-day clinical support. So we like them to be a highly trained clinical professional. Okay, careers at our agency.
Yeah, so what I passed out were some job summaries of the current openings that we have. So if, Rebecca, if you want to, yep. So a case manager, a clinical coordinator, a targeted case manager, a CCS care coordinator, and a CSP program manager. So definitely take the handouts with you guys. If you guys are interested, feel free to reach out to Rebecca and I. I don't know if you want to talk a little bit about the positions. I know we covered a lot about case management, but the clinical coordinator, TCM, or...
Yeah, our targeted case management program is more of a step down from our CSP. It's another community-based case management position that we have. Typically, the staff in that program have a bachelor's degree. They're meeting with the client 1 hour a week. That's typically the max. And they're really only focusing on service facilitation. That clinical component is usually missing. When we talk about a CSP, we're really talking about a highly clinical model that integrates many therapeutic practices. And like I said, everything you're doing with the person is clinical. A CCS care coordinator, kind of similar to a targeted case management program. You're doing a lot of facilitation around the services that they need instead of providing the direct care like you would in a CSP. But you may be spending more than an hour a week with a person. You could be spending really anywhere up to 8 hours a week coordinating all of their care. Okay, how to get hired. Do you have any comments?
Yeah, so Rebecca has really good points about how to get hired in the mental health field, right? So I'm the recruiter. I look for our generic work experience. If you held an internship, we look for that to make sure, you guys are a new graduate, but then you guys have some work experience or internship as well. Education is also a big piece. I'm sure you guys put that on your resume. What I wanted to touch on were some mistakes to avoid on a resume. So do we have a hard stop in time, or?
Yeah, you're good. We go till 10 after because we start at 10 after.
Okay.
So perhaps, in a Q&A at the end. So
okay. All right. So I'm going to let Rebecca kind of talk about maybe some of the things as far as mental health experience to list on your resume, and then I can go into some things to avoid on your resume. So.
Yeah, I think it's really important you're all doing a field placement to make sure that that gets on there on your resume. I think it's a really good idea to treat all of your field placements as if they are job interviews, because you want to make connections with your clinical supervisor, and you also want to stay in contact with your professors and instructors because you're going to need good recommendations and references. So if you do things like assessing, treatment planning, facilitating groups, or you're observing any of those things, those are great areas to put on your resume. Anything that's rehabilitative, any direct client interaction you have, even if it's in the presence of another professional or you're co-facilitating, I think that's an excellent thing. Any special projects that you've done. I know when I did a field placement at my agency, the day I started, we rolled out Epic, which was a new electronic health record. That was a really big deal to be able to participate in the launch of a new electronic health record. There were times when at a field placement, I built a policy and procedure manual. Those are things that you may not typically consider putting on your resume, but it shows initiative and the fact that somebody trusted you to give you that project. So any of those special type things that you do in your field placement, I think is great to list.
Yeah, so I actually was on a webinar, I want to say a couple of weeks ago, a SHRM webinar, and they list some of the top 10 resumes mistakes to avoid. And so I'm just going to go through them and give you guys some examples. So the number one is typos. So make sure as you're submitting your resume to a job or your ideal job, make sure it's free of typos and that someone else proofread it, because as a recruiter, we can pick out those things, and if we see a lot, it's a resume that we're probably going to put on this side, okay? Number two is lack of specifics. So for example, on your resume, you can put worked with employees in a restaurant setting, right? Otherwise, compared to recruited, hired, trained, and supervised more than 20 employees in a restaurant. So you kind of see the difference where you're really not highlighting your key accomplishment, and that's what we as recruiter, we really look for.
Yeah,
okay?
I didn't say that, but quantify anything. You know, if you are in a unit of 20 patients, put that on there. We love the things that end in ED, supervised, trained, observed, whatever.
Yep. The third thing is attempting the one-size-fit-all resume. So every position is going to be different. You want to take a look at the job description and then your resume and really tweak it to match the job description, right? So pick out some key duties and responsibilities, tweak your resume to reflect that. A lot of organizations use ATS now, so their applicant tracking system, and what that does is it takes your resume in and then it picks out keywords. And so by those keywords, it selects the resumes that are qualified for the position. So really take time to look at the job description, your resume, and tweak it to match that position that you're applying for. The fourth thing is highlighting duties instead of accomplishments. So again, some weak examples are attended group meetings and recorded minutes, worked with children in daycare setting, and then updated departmental files. Compared to a strong, it's used laptop computers to record weekly meeting minutes and compile them in a Microsoft Word-based file for future organizational reference. You see the difference, right? Another example is developed 3 daily activities for preschool age children and prepared them for a 10-minute holiday program performance. So really highlight your accomplishments and your duties. The fifth is going on too long or cutting things too short. So there's really not a rule of thumb of how long or how short your resume should be. Really just, again, highlight the key accomplishments. Make sure they're listed on your resume. Have everything on there. As Rebecca said, if you guys volunteered, did any outreach community or anything like that, make sure it's on your resume. I think, what do you guys know? Like 1 page is good, 1 or 2 page. Anything more than that is a little too much? Yeah? Okay. Number 6 is a bad objective. A lot of people sometimes when they're coming out of college, they put an objective, and that's fine. So just an example is a bad objective is seeking a challenging position that offers professional growth, right? A strong one is a challenging entry-level marketing position that allows me to contribute my skills and experience in fundraising for nonprofits. So you can see the difference. If you're going to use an objective, make sure it's a strong one. Some other things are no action verbs. 8 is leaving off important information. And then 9 is visually too busy. At the 10 I wanted to highlight was incorrect contact information. Make sure your contact information is correct. I've had numerous applications and resumes that has come through to me, and I've contacted them via email and phone, and I just couldn't get a hold of them. So make sure you double proofread, have someone look it over, and then make sure it's also a strong resume. I also, how many of you guys use LinkedIn? A couple? Okay, so if you're not on LinkedIn, make sure you guys get on LinkedIn. It's a great social networking site for professionals. I know Rebecca is on it. I'm on it as well. I was on it last week, and I came across this right here. It's in our HR form. It's mistakes people make during job interviews, and I was able to print some out, so I'll hand that out to you guys so you guys can take a look at it. Some stats, they say first impressions are determined by 55% by the way you dress, the way you act, and the way you walk through the door. So as recruiters and HR professionals, we're really looking, we're observing you guys when you guys are coming in for a job interview. The next thing is 38%, the quality of your voice, so your grammar and your confidence. If you're confident, we can see it. If you're not, we can see it as well, okay? And then 7% are the words you choose to say. So make sure you're prepared, you're professional, and you're going in confident. And there's a lot of neat other things on here I will pass out if you guys are interested as well. I did bring some brochures with me about our program, so if you guys are interested in that, feel free to stop up here. I can give you guys, and then we do have some bell therapy Chotskys that you guys can take along as well.
I think the brochures really are a great thing to take with you if you're interested in knowing what type of opportunities are available to you with an MSW out in the community. It will really go in depth with what each program offers. I know I really focused a lot on CSP today because I love CSP, and I also, again, think it's a wonderful example of taking something out of a textbook and seeing how somebody could be a therapeutic person in an individual's life, even if their role is case manager. So I just wanted to highlight from my perspective some of the great benefits to working in either community mental health or in a CSP. So a good reminder for you working in a CSP if you're feeling a little burnt out. It's a really great diversity of experience. Even though you're working with individuals who all have chronic and persistent mental illness, they're all very different. And you could see just in all of the things that I went over today, you're doing so much. You have a lot of different opportunities to participate in that person's life, whether it be employment related, housing related, whether it's doing a therapeutic group or connecting with their families. So you're just getting so much different experience. There are a lot of challenges in a CSP. This is not like a super easy group of folks to help and to serve. These are folks who do have acute crises, who do have a lot of complex needs and issues. But I'm telling you, if you can work in a CSP, I think you can work absolutely anywhere. The skills that you learn in a CSP are transitional to any type of social work job or career that you would want to go into. Many people earn their hours towards their LCSW. I finished my LCSW in a CSP, and we do lots of clinical supervision, and it's not anything that's extra or in addition. Just participating in your regular day-to-day job and meeting with your supervisor qualifies you to get your LCSW. You receive continual feedback. I think we mold the best clinicians because you are receiving day-to-day feedback on your clinical performance. We're always pushing people to be the best, to be the greatest clinicians that they can, and so there's a constant feedback loop. You're working with a lot of highly trained clinical people, psychologists, psychiatrists, clinical coordinators who are in LCSW typically, so you're getting lots of feedback and you're growing as a professional. There's a great sense of accomplishment because this is a challenging group sometimes, and when you're able to get something done or help them in a certain way, it feels really good. It's highly rewarding. You're serving this high needs group, so if you're like Susie social worker like myself, you're like, I really want to just help where help is needed, and I want to really give my all to the group that I feel like is struggling the most. Go work in a CSP. A lot of people want to work with kids, a lot of people want to work in a hospital or a hospice setting. You don't have an overwhelming people jumping up to say, yep, I want to work with somebody who's homeless, addicted to crack, and is untreated for their schizophrenia. Except me. I just think it's so rewarding and entertaining. I mean, entertaining is an interesting word to think of, but you have to find it entertaining because otherwise you would just pull your hair out. I mean, our clients are great. They say, funny things. They're very humorous, and, they joke with us and they participate in their treatment, and every day is different. You're going out into the community. On a day like today, you're spending 80% of your day out of the office just rolling around with your window down, taking your client out to do things, going to Brewers games. I mean, there's everything about that is entertaining. It is not a boring career. And again, I personally find it to be very, very rewarding. Okay, I feel like I whipped through that so fast, but I just had a lot of things that I wanted to share with you all. And so hopefully you found it rewarding, and hopefully you're able to take away something from that. But I would like to answer any questions that you have. Yes?
I had a question. Did you say in the beginning that Bell Therapy also owns like 20 group homes in Milwaukee? That's interesting. So then do you have like who works in the group homes, I guess, like who staffs the group
Yeah, so
homes?
we actually have two different departments. So we have community services, which I oversee, which is like we have 3 CSPs, our TCM, our CCS, and then we have a whole residential services department that has an associate executive director and a director. So we have what's called residential care workers, or RCWs. Those folks staff the homes. Each home also has a supervisor, and each home typically has a case manager, I think. We have a mix of DD/ID homes and mental illness homes. So those homes are staffed a little bit differently. But
So I think we currently have 5 or 6 case managers, and they're assigned to an X amount of homes. And so our RCWs, resident care workers, really work with the clients on their independent living skills. And so that may be doing activities with them, teaching them how to cook. Again, they go out to outings in the summer, which is really nice. So that's a whole nother piece. The residential piece is another piece in addition to
our company is honestly huge. We also have medical day treatment, which is for people with serious mental illness, where people come 4 days a week, either half day or full day, meals provided. We also have day treatment, which is very similar to like our Goodwill program, which is for people with intellectual and developmental disabilities, where they're doing workshops and there's a classroom and teachers and all of that. So we've got a pretty big scope of practice in Milwaukee.
That's really nice that it's all under the same roof.
Yeah.
Because as far as my experience goes, there's all those things, but they're all different
Yeah.
companies. So you have to refer, and then you get on a wait list, and then, I mean.
Yeah, our goal is really to be
Absolutely.
able, as a company, to serve somebody from the moment they're born until the moment that they pass. So our scope of practice is all reaching, no matter what happens to somebody in their life. If they have a traumatic brain injury, or they fall ill, or they develop a mental illness. We also have an outpatient clinic, which is more of the traditional psychotherapy with folks coming in. So a lot of different things.
So do people graduate from your program then, or they
Do you mean like clients?
Yeah, like-
Sure. Yeah, we have healthy discharges. The goal is always to move people on. Sometimes it's moving people to a lower level of care. Like we'll move someone from CSP to TCM or CSP to CCS. Sometimes it'll just be a total recovery discharge. So things that we look at to be able to discharge somebody appropriately is getting them hooked up with their own psychiatrist in the community, having them either become their own payee or finding somebody in the community to become their payee. We want to make sure that they have a plan to take all of their medications independently and that they have housing stability. But it certainly does happen.
We should, let's first give our guests a round of applause.
Thank you.